So now let's talk about oppositional defiant disorder, or ODD, or ODD. Nearly every child at some point will experience ODD. This is a child who throws a temper tantrum, is argumentative, refuses to obey, or perhaps refuses to complete his or her chores. However, for the child to be diagnosed with ODD, the symptoms must be more persistent and more frequent than would be considered normal behavior. And the symptoms of ODD will initially appear in the preschooler and rarely later in adolescence. Some children, adolescents may go on to develop a conduct disorder, which we'll discuss later. Children and adolescents diagnosed with ODD do not see themselves as being defiant. They feel that they're being expected to respond to demands that are just unreasonable or situations they perceive as unreasonable. Oppositional defiant disorder is generally evident before the child is 8 years old and generally occurs in males until puberty, when the incidence of ODD is equal between males and females. Um, as noted in your text, oppositional defiant disorder often co-occurs with other disorders such as ADHD or conduct disorders. Co-occurrences of other disorders with ODD creates a challenge for effective treatment. Since we have discussed the client safety is our primary concern, it's essential to note that when ODD co-occurs with conduct disorder, there is an increased risk for suicide. Some of the observations that you may make when working with a child who is diagnosed with ODD or suspected of exhibiting symptoms of ODD are the family may report that the child consistently argues with adults or those in authority, such as the teacher, the principal, even the school bus driver. The child has a history of refusing to do as he or she is told to do. This is a child that, when asked to sit, will continue to stand or pretend that they didn't hear the request, or will stand and cross their arms in defiance. The child may be spiteful and revenge seeking. He may color on the walls after he's been asked to stop playing and his toys are removed. Again, I'll keep referring to the child as he because you'll typically see ODD in males. This child is easily annoyed, or they're very touchy. If someone touches him or won't get out of his way when they're playing, he's going to lose his temper and become angry. However, the same child will deliberately annoy others and believe that his behavior is okay. He'll blame others for his or her for his mistakes or behavior, and it's always the fault of someone else. So let's examine some of the nursing interventions when working with parents or caregivers of children or adolescents with oppositional defiant disorder. First, we want to examine the quality of the child parent or child caregiver relationship. Is there evidence of bonding, or do you notice tension and anxiety between them? Um, is there antagonism between the parents and the child's temperaments? That will contribute to the child's disruptive behaviors. Does the parent do things and the child immediately has some kind of unacceptable reaction to it? For example, you notice tension and the child seems to shy away from the parent or caregiver as the parent attempts to get close to the child. He or she becomes increasingly agitated, and the parent or caregiver continues to move in an unwanted situation, and the child's behavior becomes worse. Is the parent or caregiver aware of where the child should be related to normal growth and development? Again, teaching. Do they know what their child should be doing or is expected to do at a certain developmental level? How do they appear to handle problematic behaviors? You want to watch the interactions between the parent and the child. If they're expecting more than the child is capable of, or expecting what is beyond the child's growth and development, this will contribute to the child's problems. And finally, you want to assess cognitive, psychosocial, and moral development for any lags or deficits. Immaturity in developmental competencies will result in the child's disruptive behavior. Okay, moving on to conduct disorder. Conduct disorder is a serious behavioral and emotional disorder. It's characterized by a constant pattern of behavior whereby the child or adolescent will violate the rights of others and those of society. Conduct disorder is considered a forerunner to antisocial personality disorder. There are two onsets of conduct disorder: childhood onset, which I'm going to talk about first, and adolescent onset, that I will briefly discuss later. So, childhood onset conduct disorder can be seen as early as 2 years of age, with behaviors such as irritable temperament, poor compliance, inattentiveness, and impulsivity. These characteristics can later lead to conduct disturbance. These children lack the ability to solve psychosocial issues, and as they reach elementary school, they have aggressive tendencies with adults and peers, and they continue not to be within the social acceptable norms. These children are physically aggressive toward others, especially animals. They may use weapons against animals or force others into sexual activities. They have poor peer relationships. They they lack concern for others, as well as having a lack of feeling or guilt or remorse. These children misperceive the intentions of others as being hostile, and they believe their aggressive responses are justified. Um, so I'm sure you can see how this can be a forerunner to antisocial personality disorder. These children will try to project a tough guy image. However, they have a very low self-esteem and a low tolerance for frustration. They show irritability and have outbursts of temper. As time progresses, so do their acts of outburst, and eventually they demonstrate intense anger and aggression. They simply emotionally overreact to perceived slights. You did me wrong, and this is how I'm going to act. They continue to blame others for their actions. It's always someone else's fault, and they're non-compliant with demands. Unfortunately, the earlier the onset of conduct disorder, the poorer the outcome is going to be. So for the adolescent onset conduct disorder, it's less aggressive, and the adolescent has more normal peer relations. These clients likely have they're going to have a better outcome. This group tends to act out their misconduct with their peers. For example, truancy, early onset sexual behaviors, or drinking or substance abuse, and other risk taking behaviors. Males will generally fight, steal, or vandalize whatever. They'll typically have disciplinary problems in school, and the girls are going to lie, run away, and perhaps engage in prostitution. The conduct disorder is going to result in academic failure and failure to graduate. Typically, the individual is labeled as a juvenile delinquent and is seen in the juvenile court system. Unfortunately, the connections the adolescent develops with others in the juvenile court system is going to result in worsening behavior. Frequently, those conduct disorders will also have coexisting disorders such as anxiety or mood disorder, learning disabilities, or ADHD. So, as always, safety being a primary concern, not only for the client but anyone associated with this child. In the case of oppositional defiant disorder and conduct disorder, uh, what's the seriousness of the disruptive behavior? Determine when they started and what's been done so far to manage the behavior. Hospitalizations, residential placement. These may be necessary as well as the use of medications. Some medications that you may see used with ODD and CD are the antipsychotics we've previously discussed. Lithium, anticonvulsants, and antidepressants. You want to assess the levels of anxiety, aggression, anger, and hostility the child has towards others, and the ability for him or her to control their impulses. Um, Always position yourself in a safe place. Alert team members for support in case the child or adolescent, uh, in case their anger escalates and intervention is needed. Again, you don't want to place yourself in harm's way, and it's safety. Safety is first, and we must think of that. Um, in these types of situations, at CDPC, you'll hear staff call the code gray. So be sure you have understanding of what the unit or facility's protocols for safety of not only the clients but also staff are. And finally, assess the moral development of the child or adolescent's ability to understand his or her effect of hurtful behavior on others. Do they know how hurtful they're being? Do they understand that their behavior is hurtful to others? The ability of the child to empathize with others and feel remorse or guilt. And again, like we said, these can progress to antisocial personality disorder, and they don't feel any remorse and they don't feel any guilt. So we want to try to focus in on that and see if the child has any of these things. So, as always, safety being a primary concern, not only for the client but anyone associated with this child. In the case of oppositional defiant disorder and conduct disorder, uh, what's the seriousness of the disruptive behavior? Determine when they started and what's been done so far to manage the behavior. Hospitalizations, residential placement. These may be necessary as well as the use of medications. Some medications that you may see used with ODD and CD are the antipsychotics we've previously discussed. Lithium, anticonvulsants, and antidepressants. You want to assess the levels of anxiety, aggression, anger, and hostility the child has towards others, and the ability for him or her to control their impulses. Um, Always position yourself in a safe place. Alert team members for support in case the child or adolescent, uh, in case their anger escalates and intervention is needed. Again, you don't want to place yourself in harm's way, and it's safety. Safety is first, and we must think of that. Um, in these types of situations, at CDPC, you'll hear staff call the code gray. So be sure you have understanding of what the unit or facility's protocols for safety um, of not only the clients but also staff are. And finally, assess the moral development of the child or adolescent's ability to understand his or her effect of hurtful behavior on others. Do they know how hurtful they're being? Do they understand that their behavior is hurtful to others? The ability of the child to empathize with others and feel remorse or guilt. And again, like we said, these can progress to antisocial personality disorder, and they don't feel any remorse and they don't feel any guilt. So we want to try to to focus in on that and see if the child has any of these things. So there are many nursing diagnoses appropriate for children and adolescents with disruptive disorders. I've only included a few for this lecture. Some obvious nursing diagnoses include ineffective impulse control, as evidenced by, and you can fill in the blank. Ineffective impulse control, uh, ineffective relationships with parent or caregiver, and that would be as evidenced by any tension or anxiety that both the parent, the caregiver, and the child have when interacting with each other. And risk for impaired parent-child attachment. Again, you can try to put finish that nursing diagnosis. And finally, a risk for injury, as evidenced by the dangerous and risk-taking actions during the child's impulsive behavior. So let's take a look at a few nursing interventions for children or adolescents with disruptive behavior disorders, such as oppositional defiant disorder or conduct disorder. As in all cases, we must first protect the client from harm while not placing staff or ourselves in harm's way. It's essential to provide immediate and non-threatening feedback to the client for his or her unacceptable behavior. They have to know that this behavior is unacceptable and it can't be tolerated. Um, you need to work with the client to increase the trust of authoritative figures. I mean, you don't want to come across as somebody that they can't trust, or that's going to be a perception of someone they can't trust. Use interpersonal skills to maintain satisfying relationships with with their adults and peers. Good good things or good works that they do, they get favorable response back. So you want to try to not be their friend, but lead them in the right direction. Provide immediate feedback for and positive feedback when their behavior is appropriate. I mean, if they're acting correctly, then you want to acknowledge that, so that it kind of builds their self-esteem, and help to increase their ability to tolerate frustration and appropriately express themselves. We all get frustrated. We all have times when we're stressed right out, and we all act appropriately, and they need to know how to act and how to tolerate frustration. That's going to happen. It's part of life. And use positive role models to help the client respond to an acceptable way when he or she is feeling frustrated or aggressive. You know, how does so and so act? And or just be an example to the client. And it's important to provide support, education, and guidance again to the parent and the caregiver. They need to have the support. They need to be educated on what's going on with their child or their adolescent, and they need to know where they can get the help that they may need to get through these situations.